Hello everyone, welcome to TriRide. This is Path 365, myself Srisha. So today in this session, you're going to learn about ICD-10-CM coding guidelines for injury, poisoning and certain other consequences of external causes. So this fall under Chapter 19 ICD-10-CM. So what is Chapter 19? The Chapter 19 of ICD-10-CM, it includes codes for injuries. Injuries nothing but cuts, burns, fractures, sprains and contusions. And also it includes poisoning like drugs, chemicals and toxic substances, complications of medical and surgical care, and also other effects of external causes, foreign bodies and trauma effects. So the code range is S00 to T88. So application of seventh characters in chapter 19. So what is the seventh character? The seventh character provides additional information about the episode of care. So it is mandatory for most injury and poisoning codes in chapter 19. If the code has fewer than 6 characters, so placeholder X, it is used to allow the seventh character. So what are the common seventh character values? Most categories. So A is for initial encounter. It is used when the patient is receiving active treatment. So active treatment includes emergency care, surgical treatment, evaluation and treatment by a physician, and also initial management of the injury. It is important because initial does not mean first visit ever. It means active treatment is still ongoing. Next seven character is D. D for subsequent encounter. So this is used when the patient has completed active treatment and it is in healing phase, recovery phase, routine follow-up visits and cast change, removal of sutures and physical therapy. So next seventh character is S. S stands for sequela. So sequela, it is used for late effects or complications that remain after the injury has healed. For example, like scar, chronic pain, joint stiffness due to old injury. So what is the coding rule over here? You have to first code the sequela condition. So then add the injury code with seventh character S. So what is a special thing about a fractures? So fracture codes, they have additional seventh character options beyond A, D and S. So these characters, they may indicate open versus closed fracture, routine healing, delayed healing, non-union as well as malunion. So this makes fracture coding more detailed than other injuries. So what is the key coding principle here? So provided change does not affect the seventh character. Seventh character is based upon the stage of treatment but not based upon the first sign seen by his provider and the change of hospital or doctor. So even if a new provider sees the patient, you have to use A if active treatment is still happening. Seventh character in complication codes. So for complications of medical or surgical care, active treatment, it means treatment of the complication itself. So even if the original surgery or procedure happened earlier. There's an example, T84.50XA. So T84.50, it denotes infection and inflammatory reaction due to internal joint prosthesis. So X is the placeholder and A is for initial encounter. So this means the patient is currently receiving the active treatment for the infection, but not necessarily that the prosthesis was recently placed. So seven characters are very important because they improve the clinical accuracy, they support the proper reimbursement, they reflect the patient's stage of care as well as they are often required, but they are not the optional things. So how and when to use the seven characters A, D and S. So especially for injuries, poisonings and complications of devices or procedures. I already said you that seventh character A means initial encounter. So this is used when the patient is receiving the active treatment for the condition. So what does active treatment include? It includes emergency care, it includes surgical treatment, initial E&M, antibiotic treatment for infection, as well as any care directed at treating the condition itself. So initial encounter does not mean the first visit. It means the active treatment is still ongoing. So even if the prosthetic device, implant or graft was placed earlier, you have to use A if the patient is now being treated for an infection or complication related to it. For example, a patient develops an infection of a knee processes placed 2 years ago. They are admitted now for 4 antibiotics. So you have to still use seventh character A because the treatment is active, because they are receiving the antibiotics, right? So seventh character A, it is used for each active treatment visit. So every encounter where active treatment continues uses A. So it does not change just because the patient returns again or a different provider sees the patient. Treatment spans multiple visits. So as long as the condition is actively treated, A remains correct. So the seventh character D. D means subsequent encounter. So when to use the seventh character D? After the active treatment is completed. So the patient is now in healing phase, recovery phase or follow-up care phase. So what are the examples of subsequent care? So examples like dressing changes, suture removal, physical therapy, cast change or removal, and as well as routine follow-up visits. So no surgery, no antibiotics, and there is no emergency care. You have to use the seventh character as D. So what are the aftercare Z codes? Aftercare Z codes Z47 and Z48, they should not be used for injuries, poisonings and conditions in chapter 19. Why? Because chapter 19 already uses the seventh character D to show the subsequent care. So the correct approach is you should not use a Z after care code. So you have to use the original injury code with seventh character D. And coming to seventh character S, that is sequela. So sequela, it's a residual condition that remains after the acute phase has ended. For example, like scar after a burn, chronic pain after injury, joint stiffness after fracture, and nerve damage after the trauma. So what is the correct coding rule for the sequela? You have to code the current residual condition first. Then you have to code the original injury with the seventh character S. For example, patient has a burn scar causing the restricted movement. So first you have to assign the code for scar code and then burn code with S. So this is how you have to code the 7 characters A, D and S. So what is the correct use of 7 character yes? So when using 7 character yes, two codes are required. The code for the sequela, that is a residual condition, and the original injury code with 7th character yes, as I said you earlier. So the S is added only to the injury code but not to the sequela code. So what is the sequencing rule for sequela? First you have to code the current condition, then the original injury with 7th character yes. So why this rule exists? Because sequela code tells what the patient has now. So the injury code with S explains why it has happened. So this improves the clinical clarity, data tracking, legal and reimbursement accuracy. So then coming to guidelines regarding coding of injuries. So you have to assign separate codes for each injury unless a combination code is provided that includes multiple injuries. For example, patient has head injury as well as arm fracture. So code both injuries separately unless a combination code or combo code exists. So category 2T07, which is unspecified multiple injuries. So you should not use T07 in inpatient coding unless detailed documentation is not available, where unless no more specific codes can be assigned. Because T07 is the last resort, you have to always try to code the specific injuries. So next coming to traumatic injury codes. S00 to T14.9. What not to code here? So this code should not be used for normal healing surgical wounds, routine post-operative care, Surgical wound complications. Why? Because surgical wounds are intentional. Injuries are unintentional trauma. So you have to use that codes for aftercare of surgery. So T81 to T88 for complications of procedures. So what is the sequence of injury codes? So the code for the most serious injury is sequenced first. So this is determined by the provided documentation, focus of treatment, severity and threat to life or function. So sequence what the provider is mainly treating. So next is superficial injuries. So superficial injuries, these are the minor injuries involving skin or soft tissue only. So abrasions, contusions, nothing but bruises and minor scratches. So do not code superficial injuries when they occur at the same site as well as along with a more severe injury. For example, patient has deep laceration of forearm, abrasion of the same forearm. So you have to code only the laceration, but you should not code the abrasion. So why? Because the reason is superficial injuries are considered included in the more serious injuries at the same time. So minor injuries disappear whenever a major one is present. So next coding guideline is primary injury with damage to nerves or blood vessels. So in the main injury is something like fracture or laceration and it causes minor damage to peripheral nerves as well as blood vessels. So what is the correct coding sequence? So you have to sequence the primary injury first. Then you have to add the additional codes for nerve injury, example category S04 and blood vessel injury category S15. Here is an example. So fracture of humerus with minor radial nerve injury. So you have to assign the fracture code first followed by nerve injury code next. So you have to always sequence the nerve or blood vessel injury first. So next is iatrogenic injuries. So what does iatrogenic mean? Injury caused by medical treatment, surgical procedures or diagnostic interventions. So examples like accidental puncture during surgery, nerve damage during a procedure or post-operative bleeding. So what is the coding rule for iatrogenic injuries? You should not use chapter 19 injury codes for iatrogenic injuries. Instead, you have to assign a complication code from T81 to T88 categories. Why? Because chapter 19 injuries are for accidental trauma. So medical caused injuries are the complications but not the injuries. There is an example. Patient sustains bowel perforation during surgery. So when you code S36, it gives you an error. So what is the correct code? 381.2 from the complication codes T81 to T88 category, which determines the accidental puncture during the procedure. So in this way, you have to code the iatrogenic injuries. So fractures can be coded based upon the multiple fractures, the default rules and seventh character use. So there are multiple coding principles for fracture. So each fracture is coded separately by site. So you have to follow the same multiple injury principles used for other injuries. So this applies to fractures in categories such as S02, which is for skull and facial bones, S12 for cervical spine, S22 for thoracic spine and ribs, S32 lumbar spine and pelvis, S42 shoulder and upper arm, S52 forearm, S62 wrist and hand, whereas S72 femur, S82 lower leg and S92 for foot. So you have to code each fracture site individually when the documentation allows. So what is the importance of the medical record in detail? Because the coding depends upon the site, laterality, type of fracture and the healing status. So if documentation is limited, you have to code to the highest level of specificity available. So more documentation gives you more accurate fracture coding. So what is the default coding rules for fractures? So default coding rules is for if the fracture is not specified as open or closed, then the default type is coded as the closed. And next, the fracture is not specified as displaced or not displaced. The default type is coded as displaced. So these defaults are used only when the documentation is silent. And the next coding guideline is initial versus subsequent encounter for fractures. So fractures have more detailed 7 characters than other injuries. So the initial encounter is fractures. So when to use? When the patient is receiving active treatment for the fracture. So again, active treatment includes emergency care, surgical fixation, manipulation, reduction, and initial casting or splinting. So in this case, the 7 characters for initial encounter are A, B, C. So this is used depending upon the fracture type such as open fracture classification. Then coming to subsequent encounter fractures. So when to use subsequent encounter? When active treatment is completed and the patient is in the healing or recovery phase. Examples like follow-up visits, cast change or removal, X-ray to check the healing and physical therapy. So 7 characters for subsequent encounter may include D for routine healing, G for delayed healing, K for non-union or P for malunion. So for example, patient had a tibia fracture. So surgery was done last month. Now patient comes for cast removal. So you have to code fracture with subsequent encounter. Why these rules matter? Because they ensure accurate severity reporting, correct reimbursement and proper injury statistics. So fractures are the high impact diagnosis codes. So accuracy is very critical in this fracture codes. Complications of surgical treatment for fractures. So you should not use fracture codes for complications caused by surgical repair of fractures during healing or recovery. So instead you have to use the appropriate complication codes from the category T81 to T88. So what are the examples of surgical complications? Post-operative infection, hardware failure, surgical wound dehiscence. So if a problem is caused by a surgery, it's a complication, but it is not an injury. So what are the complications of fractures, malunion and non-union? So non-union is nothing but fracture fails to heal and malunion is a fracture heals in an incorrect position. So what is the correct coding rule? These are coded using the fracture code itself with a specific 7th character but not a complication code. So 7 character options are non-union for K, M, N and malunion for P, Q, R. So coming to delayed treatment for malunion or non-union. So if a patient delayed seeking care for a fracture or non-union and now requires active treatment. So assign the initial encounter 7 character but not the subsequent. So delayed care plus active treatment, it covers the initial encounter. So there is a guideline regarding open fractures and Gustilo classification. So what is the Gustilo classification? A system which is used to classify open fractures based upon wound size, soft tissue damage, contamination. And this is commonly used for forearm, femur and lower leg including ankle. So the correct coding rule is here. The 7th character for open fractures is based upon the Gustilo type. So if Gustilo type is not documented, so default is to type 1 or type 2. You have to use appropriate 7 characters, either B, E, H, M, Q, depending upon the encounter and healing status. If there is no Gustilo type, you have to assume type 1 or type 2. Then osteoporosis related fractures. So this is very important guideline regarding osteoporosis. So if a patient has non-osteoporosis and sustains a fracture from minor fall or minimal trauma. So do not use traumatic fracture codes that is from S00 to T88 category. So what is the correct coding? You have to use category N80 osteoporosis with current pathological fracture. Why? Because a healthy bone would not fracture from the minor trauma. So the underlying cause is osteoporosis but not the injury. So the example is elderly patient with osteoporosis falls from standing height and fractures hip. So you have to give the code M80.051, which is the correct code instead of the fracture code. Aftercare Z codes. So aftercare Z codes and traumatic fractures. So Z codes for aftercare, that is Z47 or Z48. So they should not be used for aftercare of traumatic fractures. So what is the correct approach of assigning the codes? You have to continue to use the acute fracture code. That is an S code. So you have to change only the 7th character to reflect the stage of the care. Whether D for subsequent encounter, G for delayed healing, K for non-union and P for malunion. So fractures until healed. So they never switch to Z after care. For example, patient returns for cast change after tibia fracture. Then you have to assign the code S82.201D because it falls under subsequent encounter. So next guideline is multiple fracture sequencing. So how do you code multiple fractures? So when multiple fractures are present, you have to sequence the most severe fracture first. So how the sequence of the severe fracture will be dependent? So severity is based upon whether the fracture is open or closed, whether the fracture is displaced versus non-displaced, whether there are any complications like non-union or malunion, and if there is a need for surgery or not. So for example, there is an open femur fracture plus closed wrist fracture. So femur fracture coded first because it is the open one. It is more severe than the closed one. So the third guideline is physeal fractures. Physeal is also called as a growth plate. So what is a physeal fracture? A fracture involving the growth plate in the children or adolescents. So this is classified by Salter-Harris types 1 to 5. So you have to assign only the physeal fracture code. So do not assign a separate code for the specific bone. So the physeal fracture code already identifies the bone involved and the type of the growth plate injury. So only physeal code is enough here. And example is Salter-Harris 2 fracture of a distal radius. So only the physeal fracture code is assigned. So next coming to coding of burns and corrosions. So what is the difference between burns and corrosions coding? So the type of burns is electrical burns, radiation burns, and as well as the corrosions. So burns are due to heat, fire, steam, and hot objects. So electrical burns are caused by electricity. Radiation burns are caused by radiation exposure. Whereas corrosions, these are caused by chemicals like acids or alkalis. So sunburns also have a separate codes. Chemical burns are always coded as a corrosions. So what are the coding guidelines? So coding guidelines are the same for both burns and corrosions. So this includes degree, that is first degree, second degree or third degree of the burns. And second is the body site. And third is the extent, the total body surface area. And the fourth one is external cause codes. So burns are classified into 3 factors, obviously first degree, second degree and third degree. So the first degree of burns, they have redness, pain and there will be no blisters. Whereas second degree of burn, you can see blisters as well as a partial thickness. Coming to third degree of burns, there is a full thickness tissue loss and extent of burn. So this is measured as TBSA, that is total body surface area. So this is coded using T31 burns or T32 for corrosions. This is used especially when burns are extensive and multiple body regions are involved. And the third one is agent, that is cause. So this is coded using external cause codes, that is X codes. So examples like fire, hot liquid, electricity, radiation. So what caused the burn must be coded. So next, burns of the eye and internal organs, that is T26 to T28 category. So this includes the burns of eye and internal organs. So these are coded by the site only but not by the degree, because burn depth cannot be accurately assessed in these areas. For example, like burn of cornea. So you have to assign the code which identifies the eye but not the degree. So next guideline regarding to sequencing of burn and related condition codes. So how do you sequence the burns? So you have to sequence first the code for the highest degree burn when more than one burn is present. In the special sequencing scenarios, when multiple external burns are present. So how do you code? So when the admission or encounter is for the treatment of multiple external burns, so you have to sequence first the highest degree burn. For example, like second degree arm burn plus third degree chest burn. Then you have to code the third degree chest burn first, followed by second degree arm burn second. So in second scenario is when there are both internal and external burns are present. So the reason for the admission decides the principal or first listed diagnosis. When a patient is admitted mainly for the inhalation injury and patient admitted mainly for the skin grafting. So here the internal burn coded first, and the second case for skin grafting, the external burn coded first. So why was the patient admitted became the reason for the first listed diagnosis. So in the third condition, burns with related conditions such as smoke, inhalation and or respiratory failure. So when burns occur with conditions like smoke inhalation, acute respiratory failure and circumstances of admission determine the sequencing. For example, like admission due to respiratory distress. Nothing but you have to code first the respiratory failure. And the second example is admission due to the burn wound care. In this case, you have to assign the code first the burn. So the burns are always sequenced depending upon the reason for the encounter, which degree the burn is, and the site also plays a specific role. So this is for today's session. I hope this session has helped you. So in the next session, you will be able to learn the continuation of Chapter 19 ICD-10-CM coding guidelines regarding burns injuries. Thank you.